So we're going to talk about dysplasia detection in IBD and whether you should be using chromoendoscopy routinely, which is a question that comes up often. And I'll give you the latest information and some suggestions, and I even have a video showing you a little bit of how I do this. I also wanted to point out that I am on Twitter for those who are interested in following me, and I've been tweeting from this meeting with some updates about what our expert colleagues have already said up here. And one last thing, for those who haven't been down yet, we did open our new IBD unit at U of C, and we're delighted to have you come visit, and we're going to try to host something for all of our referring colleagues to come see the new place. We have a inpatient unit on the 9th floor of this beautiful new facility. So we'll talk about an update regarding your approach to cancer and dysplasia risk in your patients. And one of the main messages that I'm going to talk about regarding prevention of cancer is actually a similar message to treatments that you've already heard, which has to do with individualizing your approach to patients. Not all dysplasia is the same, and understanding how and who you can follow patients successfully is a really important message today. In addition, I'm going to do my best to provide up-to-date information on chromoendoscopy and other approaches to better visualizing the bowel, so you'll understand when it might be appropriate and where the science currently stands. And I'll also point out for you a bit more about where we are with the concept of chemo prevention. So there have been major advances in cancer prevention in IBD in recent years. We have documented that cancer is less prevalent than previously described or believed to have been. Many in clinical practice who are experienced have been saying that for years, that they just didn't see cancer in their colitis patients like the previous literature would have suggested. We've also confirmed now that inflammation indeed is an independent risk factor. This may be intuitive to all of us, but it took a while to figure it out and incorporate it into our practices, and we'll come back to that. We've learned that doing all those random biopsies that we've been instructed to do all those years is actually of quite low yield and probably not worth it in most patients. For many of us who have been following those guidelines, it's been reassuring to do the biopsies and feel like we're doing something, but we've learned that that probably is not worthwhile and you can abandon it for many of your patients. We'll talk more about that. We know that chromoscopy or chromoendoscopy is a superior approach to finding dysplasia compared to white light. But what we don't know yet is whether or not that changes outcomes, and we'll talk more about that. 5-ASA may not be chemoprotective despite all the enthusiasm for it being so, and thiopurines may be, and I'll tell you some more about that. And lastly, I'm going to propose to you a model of risk stratification for follow-up of your patients with dysplasia. So the first thing I wanted to share with you was this updated meta-analysis. Very often people have shown you the older meta-analysis from 2001 that looked at all the old studies of cancer and ulcerative colitis and said that the risk was as high as 30% when patients have had disease for as long as 30 years. In this updated meta-analysis, looking at the distinction between referral populations and population-based studies, you can, I hope, appreciate the difference between what we see in the referral centers and what have been reported in the older studies and what is in fact measured when you look at larger claims data or population-based data. So it doesn't mean that there isn't an increased risk for cancer in people with colitis, but it does give us a bit more perspective on different types of patients and the potential bias in some of these studies. It also doesn't mean that we should get away from doing our surveillance exams. In fact, what is measured here in the orange lines, looking at the population-based values, may actually be reflective of us effectively reducing cancer in our population with colitis, either by sending them to surgery, using our medical therapies, or by doing surveillance properly. Now, it isn't new to understand that inflammation can lead to cancer. You can look at a variety of other human diseases where either chronic infection or chronic inflammation is associated with precancer and cancerous states. And among that long list at the bottom is now ulcerative colitis and probably Crohn's colitis as well. In order to have proven this, or at least demonstrated the association in ulcerative colitis, we really needed to have a large population of patients who were followed over some longitudinal period of time and collected information about the degree of inflammation in those individuals to demonstrate that, in fact, it is an independent risk factor. And now that there have been 3 studies that have confirmed this, I think we can be confident in understanding that. So the next logical question becomes, how do you incorporate that into your practice and into your follow-up with these patients? And I'll give you some ideas. It doesn't get away from some other established risk factors, or at least associated risk factors for cancer in IBD. Specifically, longer duration of disease. The time patients have had disease remains a significant risk. The greater extent of colonic involvement, the inflammatory activity, as I mentioned, having a family history of colon cancer independent of a family history of IBD, primary sclerosing cholangitis, for reasons that we don't understand, is definitely a distinct, significantly affective condition, comorbid condition. Younger age of diagnosis, which seems independent of duration. It may be because younger patients may have more active inflammation. There may be other reasons. Backwash ileitis may also just be reflective of the degree and extent of inflammation, but it's been reported. Finding a mass or a stricture in the colon is an independent risk for subsequent or coexisting dysplasia and cancer. Having prior dysplasia, that used to not be listed as a risk factor because anyone with prior dysplasia was supposed to have had their colectomy already. But now we recognize that if you're following them, this is a risk factor for subsequent dysplasia and cancer. Pseudopolyps, which may be a surrogate for previous severe inflammation, as opposed to what people previously said, which is pseudopolyps just made it impossible to see. So there may be a combination of those two factors. And consistently in a number of trials now, men are at higher risk than women. So again, it's better to be a woman than a man. But this has been shown multiple times. So if you're going to think about how you might stratify your own patient population, think about the male patient with extensive disease who's always inflamed and sort of lives with the disease, and when you do their surveillance exam, you're always finding ongoing active inflammation. That's a patient who's at the highest risk among your cohort, and maybe not the patient who's a woman who every time you do her surveillance exam, she's had complete mucosal healing and she hasn't relapsed in 3 or 4 years. So in order to think more about how you prevent cancer in a group who are at risk, you have to understand a bit more, not only about the risk factors, but about the accuracy of your detection methods. So if you're going to use a colonoscopy, for instance, you want to know what's the likelihood that you can find what we might call the true prevalence of dysplasia in that individual patient, and how significant is that dysplasia in terms of predicting their likelihood of either a synchronous or metachronous cancer. You also have to understand what your prevention strategies are and what your outcomes of interest are. If you're an oncologist, the outcome of interest is preventing death. Thankfully, that's rarely something we have to think too much about in our population. So our outcome of interest may be that we're going to try to prevent colectomy, and then subsequently we can think about pushing the bar back a bit more and prevent dysplasia altogether. There's a variety of ways to think about this. So as we refine our approach to cancer prevention in IBD, we can look at each component of this complex formula and see where we're making some progress. One of the major areas we've made progress has to do with our ability to see and to detect dysplasia. So I put together this table that shows progress that we've made from the top to the bottom, so more recently is at the bottom of the table, and the modality that we use to detect or find the cancers or precancerous findings, as well as the prep and other things related to it. So for instance, when you just use physical examination, of course, by the time you actually find something, it's going to be more metastatic or spread, so that's not very relevant. But if we look back to the history of finding cancers in ulcerative colitis, to the barium era, for instance, they mostly saw just large lesions. And those large lesions and tubular colons were, of course, described by my colleagues in the early days as being mass lesions in the colon, and of course there was a cancer associated with it because your detection was limited to gross detection by barium. As you move down through fiber optics to even our early digital scopes, in the early days, the description, which was actually the term was coined at the University of Chicago, and one of the authors of those early papers is here at this conference today, hi Jerry, was the DALM. And DALM were thought to be very important because they were associated with dysplasia, and these patients had a high risk of concurrent cancer. But we also recognized that dysplasia was hard to find, and when you found it on random biopsies, you were lucky and you should take the colon out. But with the advent of digital scopes, we've started to appreciate that we can see most dysplasia. What we previously thought was invisible is actually visible. And as we move forward to other ways of looking, like using our chromoendoscopy, now we can see even more. It's kind of like looking at the surface of the moon. The closer you get, the more you appreciate the variability in it, and the more you might be able to find. Now, going back to my formula, the more you can see, the greater the likelihood you can effectively and safely follow patients rather than sending them immediately to colectomy. And that's where the evidence has tried to move us. Now, having said all that, it's worthwhile to remind you what the guidelines are, so we're not getting too far afield here. The ACG guidelines, which have not yet been updated but are coming with an update, still say that after 8 to 10 years, you'd want to do random biopsies throughout the colon. The concept is to do a systematic mucosal sampling. That's what the guidelines are based upon. And when you have high-grade dysplasia, they go immediately to colectomy. For low-grade dysplasia, you consider colectomy, and for other things, you want to address it either with a repeat exam or treating inflammation. If you wanted to know about Crohn's, there's an AGA position statement that says that for Crohn's of the colon, when it's at least 1/3 of the colon, your approach is similar to UC. So that's where currently these things stand in the U.S. And I would suggest to you that this is a bit out of date when you see the rest of the data that we know. First of all, we still don't have any prospective evidence of mortality benefits, so the oncologist would shrug at what we're trying to do here. We have low rates of observer agreement and histopathologic observation, so that's why we always say to you, get a second opinion when you have dysplasia. I've always asked, why don't we get a second opinion when there's no dysplasia too? And I'll tell you why in a minute. We also say that in our current approaches to dysplasia prevention, we haven't really done a good job of risk stratifying based on how much remission they're in or how much inflammation there may be, et cetera. And we haven't adjusted our guidelines yet for improved technologies. So first, let's review what we know about random biopsies. In general, they are a very low yield. In fact, they're of such low yield that we have a general theory that people who actually find something on a random biopsy probably saw something that they were biopsying and didn't document it, or their subconscious led them to biopsy that particular area. So a true dysplasia on a random biopsy is such an unusual finding that we've started to think that if it's only a single biopsy, we may want to repeat the exam and really spend more time. That's one of the compelling reasons, by the way, to put your biopsies in different jars from different segments if you choose to approach it this way. So then you can know which area you want to go back in and spend more time and focus your energies. And that's one of my messages about chromo that I'll share with you. In addition, we've started to appreciate a few other things about our pathology colleagues. It is hard to find dysplasia, but they're actually quite good when there's no dysplasia or when there's cancer or high grade. So that's why you don't have to get a second opinion necessarily if you get a negative result from all your biopsies. So if there's no dysplasia, based on what's been studied among experts and community community pathologists, you can be fairly confident that it's a correct reading. Where they get really hung up is in the indefinites and low-grade dysplasias, and that's when it is advised that you get a second opinion, have somebody else look at it, and try to get an expert GI pathologist to weigh in on it so you'll have a good sense of what you're doing. We also know from 2 retrospective studies, and actually there's a third one that I should add to this slide, that most dysplasia and all cancers in these analyses have been visible to us. And maybe you feel that way too. The morphology of dysplasia can be in different ways. It can look like a typical polyp that we're used to, but it can also look like just a raised flat lesion. And as we appreciate flat lesions in the non-colitic patients, we can also see them in the patients who have colitis. So the per lesion sensitivity means the likelihood of detecting a lesion and seeing it in these analyses that is dysplastic. The per patient sensitivity means recognizing that your decision making may be the same if you find one dysplastic focus or multiple. So the point is that if you saw even one thing that you thought was associated with dysplasia in the patient when you did your colonoscopy, that counted as a positive, even if you didn't see all the dysplasia. And you can see that we approach 90%. And this is retrospective. This isn't saying going forward. Take a really good look when you scope and see how good you can find. We also have appreciated in a couple different studies, this happens to be our own series at U of C, that there's a distinction in the outcome if you decided to follow patients with polypoid or raised dysplasia compared to those who we might say are flat or even historically the invisible or random dysplasia. And patients who have polypoid lesions that are discrete and removed by you seem to have a lower likelihood of progression of the dysplasia to higher grade lesions over time. So that gives you some reassurance that if you're following patients carefully, you can do so. I would just encourage you to understand a little bit more about that patient, and I'll tell you that in my summary statement. So now let's talk a little bit about chromo. So what is the utility of enhanced visualization? If you can see more, what does that actually give you? And should you be doing that in your practice, and how do you do it? So it's not debatable, based on number of studies, whether chromo using dye spray can find more dysplasia. It is true. Compared to conventional white light colonoscopy and a variety of tandem studies, chromoendoscopy can find more dysplastic lesions than white light. The next question you should be asking, though, is if chromo finds all these dysplastic lesions, have I been missing dysplasia all these years in all my patients? And if you believe dysplasia is associated with cancer, which we think it is, where are all the occult malignancies in your population? So when we ask that question, the next thing to say is, well, maybe what we're seeing when we find more dysplasia by chromo are lesions that don't always progress, or maybe they're lesions that are not as clinically significant. So if you want to know where are all the occult cancers that we're missing, you'd like to know what's the follow-up to all those chromo studies that I just showed you. And there's only been one study that has follow-up. It was the one by Jim Marion and colleagues in New York City. And in their follow-up of their patients who had dysplasia found on chromo, 5 of them had a colectomy because of ongoing unresectable low-grade dysplasia. None of them had cancer. So in order to adopt something that may be time-intensive and require all of us to be trained so we understand how to use something like chromoendoscopy, we really would like to know that it changes outcomes and that it changes what we need to do as a practice. We haven't quite gotten there yet, even though in Great Britain and in other places people have adopted this as standard of care. And I'll tell you what I think about that. So there are a number of challenges to adopting chromoendoscopy in our practices. First, it has a perception of being time-consuming and expensive, meaning it takes your time and your supplies. It's unclear if it changes outcomes, both cancer or mortality. Many patients won't qualify. Think of how many patients you do surveillance colonoscopies on, and when you get in there, they're actually inflamed, even though they say they feel fine. So the estimates from the published literature, including our series that Steve mentioned earlier, are 30 to 50% of the time we're going to find inflammation when we go in there to do our surveillance exams. And secondly, how often when you do your surveillance exam is the patient not really prepped very well? Well, you need a patient who's clean and who ideally is in remission in order to do this effectively. So there's lots of patients who are going to fall out of that potentially eligible cohort. In addition, there's not consensus in our field yet, and there's not a defined training pathway or competency requirement. So there are some guidelines for chromo, and they're abbreviated here with this approach called SURFACE. Choose the right patients, meaning you don't want people with active inflammation or poor preps. Unmask the mucosal surface, meaning you want them to have a very clean prep, and actually we prefer a drier prep when possible. Reduce peristaltic waves. That means either reduce them because you're using an opioid analgesic during the procedure, or perhaps even using glucagon, which has been described. Full staining the length of the colon has been recommended, but not yet endorsed. Augmented detection with dye spraying, whether it's indigo carmine or methylene blue. Crypt architecture analysis and learning what pit patterns mean, and this is all something new. Although I'll remind you that one of the things that dye spray can do is really demonstrate for you raised lesions better than not having it. And then targeted biopsies. You can get away from your random if you're comfortable that you're looking for things. Now, just before I tell you that I think that we should all be doing this, I don't. However, I think that a selected approach to chromo, looking for specific things, can be used in our practices. This is how I do it, and I've shared this formula with lots of my colleagues now. I prefer methylene blue because it's an absorptive dye. It gets absorbed into the cytoplasm. You don't have to rely on gravity to shift the patient around. Indigo carmine is a surface dye, and in order to get it where you need it, you sometimes have to spray in different locations and even move your patient. Having said that, some people are nervous about methylene blue because of the potential, in theory, that it could cause or increase the risk for dysplasia. That hasn't been proven, and I'm not sure that I have seen any evidence that convinces me otherwise, so I think this is a superior dye. I use a sterile irrigation solution that I hook up to our power wash, and this is a 500 cc bottle that I empty half of it out, 250 cc's, with 2 of the 10 cc vials of 10 milligram per ml methylene blue mixed in. So that's my standard formula. Our nurse mixes it up. Notice she's next to the sink. Don't mix it up on top of the patient's medical records. which we've learned about, and use your power wash. I usually go in all the way to the cecum using my standard approach, and I clean as I go. Once I'm at the cecum and have sucked everything that's remaining in there out, I then have them switch the bottle over to my blue. I also then take advantage of gravity. So know where things are going to go. You can spray with less dye because then it just goes where you want it. So if you spray at the top of the bowel and let gravity take it on either side, you use a lot less spray dye, and it's a very efficient way to deliver this and to get some beautiful images. Now, it is helpful to know about pit patterns, but I want you to know that for the novice doing chromoendoscopy, you may just find that it's useful to help define borders of existing raised lesions or to help you find raised lesions. But there are some different pit patterns that have been well described to be associated either with a benign finding like a hyperplastic polyp towards the left there, and those that look more malignant or potentially onerous like the ones on the right that are associated with dysplasia or even cancer. You can learn these, and over time you'll get quite good at appreciating what they mean. This is an example of a patient where we just did this a couple weeks ago. There's the lesion that you might appreciate here with white light, and I'll point out to you that in this particular picture there's a little adherent stool there. That's actually a clue. When you see adherent stool, always think that there could be a lesion underneath it and wash that away. That's something that is actually sometimes helpful at finding the lesion. But here's selective chromo of this particular site, and you can see how nicely it defines the borders of that lesion in both locations. But clearly this is sort of an ominous looking lesion, both because it's flat and spreading, but also because if you can see it, the center looks depressed. And we worry about that type of lesion. I actually approached this with endoscopic mucosal resection. We raised it up with epi and then resected it, and then probably more for me than for any other reason, I used clips to close the defect. This particular lesion ended up being low-grade dysplasia, even in that depressed center, and we felt like we got clean margins on it all the way down with that endoscopic mucosal resection. Now, that may be more advanced than you're comfortable with, so the part to remember is the upper two pictures, which is the ability to define lesions and see borders well with chromo. This is a video, if you guys can hit play for me, that shows you what it actually looks like when you spray the dye and how quickly things around it can really highlight. This abnormal fold had me suspicious, and now look at, you can actually appreciate the pit pattern there. Can you see that? For those of you in the front of the room, I'm sure you can. But hopefully you can get a sense for how I can see the margins of this abnormal fold and that pit pattern. That lesion actually was high-grade dysplasia with a focus of carcinoma in the middle of it. And so that's where we can actually pick up something quite nice. And this patient ended up going for a colectomy and did not have spread of his lesion beyond. What about narrowband imaging? So for those who have it on your processor, it's just a button, right? So could we just turn on the filter and look with that, and does that help us? Well, according to 3 different studies now, it looks like narrowband is not better than white light for what we might want to do. So the answer to that pretest question about this is not that narrowband is better than white light, even though you may think it is. It has been shown to have some benefit in the non-colitis population, and I'll tell you that I use narrowband a lot in my colitis patients when I'm not doing full chromo, and I tend to like it, but this is what the evidence says, and you should be aware. So one of the challenges is that as we get better at detecting dysplasia, we're going to find smaller lesions, and we have to have an appreciation for what we should do with all these lesions. We also need to better define what our colleagues need to do in practice. How do we train people? How do you become competent? And is this yet standard of care? And I'm here to tell you that it's not standard of care yet. If you look at the guidelines in the ACG and the AGA, which I summarized for you, they comment on chromo. ACG says not yet. AGA says in special cases, and they don't define it much further. The British Society of Gastro says yes, it's recommended. And ECHO guidelines from 2008 acknowledge that it's superior, but they don't go so far to say that it should be done by everybody. So as of this lecture right now, it's not standard of care in the U.S. It might be something that enhances your practice if you're very interested in it, and you can certainly learn more about it and start using it to see what you're doing. The British Society has actually endorsed it and say that you should do it. So they break patients into low risk, intermediate risk, and higher risk populations. And they say that based on how clean it is, and if you do chromo, you might actually have follow-up that is as distant as 5 years for your colitis patients. I don't think we're quite ready for that, but I'll point out to you that they say that if you do dye spray, the patient has complete mucosal healing, and there's no dysplasia, and you can go 5 years. If they have some mild inflammation, you bring them back sooner. So they stratify their intervals based on how much inflammation there is, which is of interest, and I think a better way to think about this than automatically escalating therapy. So I'll end with just one or two more points. One is, of course, this increased emphasis on quality measures. In people without colitis, quality measures are related on adenoma detection and withdrawal times. Well, we're going to start thinking about some similar things for IBD, but it's such a rare event to find dysplasia that it's hard to imagine how we're going to define that. In the meantime, I would say that you should be very careful in defining what you're doing and how you're looking. In terms of billing for chromo, there isn't a single separate CPT that you can add when you do chromo. The only thing that I've been doing is adding the 22 modifier, which is for an unusually long procedure, and we haven't had trouble getting that part reimbursed for the 30 cents that you get. Just two slides on chemoprevention. For 5 ASAs, we thought that overall 5 ASAs may have some protection against dysplasia and cancer in this meta-analysis. Subsequently, there have been a number of studies that have suggested maybe not, and I'll remind you that most of these studies did not control for inflammation. So maybe the most significant confounder is the degree of inflammation, and therefore it may not be as enthusiastically chemoprotective as we thought. But what about azathioprine and 6-MP? This is very interesting, and the mechanism isn't fully understood, but consistently in a number of trials now, these have been associated with significant risk reduction of dysplasia and cancer. And even in a couple of trials where they controlled for degree of inflammation, it was found to decrease the risk. So I think more work needs to be done in that area, but it's nice to know that when everyone's worried about lymphoma risk, we might actually have a therapy that is reducing the risk of dysplasia and cancer in the colon at the same time. So the last point is just this. Stratify dysplasia in your individual patients. It's individualization of risk prevention, cancer prevention, just like individualization of treatments. Understand the grade of dysplasia, the morphology, whether or not there's a field effect or synchronicity, and whether there's longitudinal follow-up. Patients who have high-grade dysplasia that's in flat mucosa or multifocal or metachronous are people who should be going to colectomy. Patient with a single lesion that maybe you've resected completely that was low grade might be someone you can follow safely. And that's how I would suggest you leave here today. Rather than being too confused, think about your individual patient, what their compounded risks are, and approach them that way. So I'll summarize and just say I'd like you to think more about stratifying. I think chromo has a role for some patients and some lesions, but I'm not here today to tell you this is standard of care, especially if you're not sure how to do it yet. Hopefully you've taken some pointers away from this talk that can enable you to feel more confident in using it, and I'd be happy to have you come visit and watch a case or two or to explain this further for any of your individual patients in the future. Thank you very much.